All right. So, how many are you in the class?
More
Who's the
than
class rep?
100.
Who's the course rep? Can I have the course rep? Is the course rep online?
Yeah, 450 for 450.
Course rep, what's your name?
Caleb, say Caleb.
Caleb. All right. Um, all right. I am Shadrach Chi, and I'm really sorry. I'm not at the office at the moment. I'm not home either. But I'm actually having this class with you from a car. So there might be a little bit of noise from time to time. That said, I will try as much as possible to eliminate all the noise so that we can have a successful lecture. Course rep, I was expecting to even hear from you last week, but unfortunately, that was impossible. I was even thinking that you were not having your timetable, and for that matter, you didn't know what you had uh, at a point in time, so you just decided to keep mute. Not knowing you were all given that information, but then you more or less decided to keep mute about it.
Oh,
So
say, please, are you different from the one that tested me right now? I should send a link to
no,
you.
no, I this is my first time even hearing from you because I I
Hey,
I
uh,
honestly don't know anything about you. I didn't even know the name of the course rep until I asked on the page now.
hello.
Yes. Yeah. All right. So
Hello, Shadrach.
hello. Mr. Ernest. Hold on.
Hello. Good afternoon, class.
Good afternoon.
Good
Yes.
Good
afternoon, sir.
afternoon, sir.
Good
Yes. Good afternoon.
afternoon.
How are you?
We are
You are
fine,
doing
thank
We
good,
are
you.
you?
well by
I'm
God's
doing
grace. What about
well.
you?
Yes, I'm fine. Sorry for the
Okay.
inconveniences created, right?
Okay.
Yes, I'm supposed to handle this with Sir Shadrach, but Sir Shadrach is in the car and I needed to take over. We will talk to you later. But today, I'm taking you through the introduction so that later we will know how to move on. Is that correct?
Yes, please.
Yes, say.
Sir.
All right.
So you're the
That's
one that
correct.
chatted me right now. So
Yes.
that,
So we will sort
okay,
things out later,
okay,
and then we will
okay,
let you know. Okay. Sure.
okay, good.
Okay. So it's the same course, medical nursing one, semester one, for this particular course. So you are January batch, and that is the course description. So you are going to have an assessment of fluid and electrolyte balance, and that is the beginning of medical nursing. Once you comprehend this content, you can understand the various systems. So let's all go through just some few minutes, and then we hit the road running. So let us embrace the content, know what you are expected to do this particular semester, and how to prepare yourself for nursing one medical medicine. So I'm going to take you through this. So the first is to consider fluid and electrolyte balance. So we look at gastrointestinal, endocrine, and renal systems. It also equips you with the theoretical knowledge and practical skills needed to perform accurate patient evaluations. Emphasis is placed on understanding normal physiology, identify deviations from normal functions, recognizing common clinical manifestations, and interpreting findings to support early diagnosis and holistic nursing care. So this course also highlights interpretations or interrelations between these systems in maintaining homeostasis and overall health. So by the end of the whole semester, you should be able to explain the anatomy and physiology of the gastrointestinal, endocrine, and renal systems, as well as principles of fluid and electrolyte balance. So demonstrate appropriate assessment techniques, including history taking, physical examination, and laboratory interpretation relevant to these systems. Identify normal versus abnormal findings in fluid and electrolyte balance, gastrointestinal, endocrine, and renal assessment. Recognize clinical signs and symptoms of common conditions such as dehydration, electrolyte balance, or imbalanced peptic ulcer disease, diabetes mellitus, thyroid disorders, acute kidney injury, and chronic kidney diseases. Accurately document assessment findings using professional nursing terminologies. Integrate assessment data from this system to develop comprehensive and patient-centered care plans. Apply critical thinking and clinical judgment in prioritizing patient needs and planning appropriate interventions. So physical assessment here, unit 1, the content says you are supposed to do what is known as overhydration and dehydration, isotonic, hypertonic, hypotonic, heat stroke, solute excess, solute deficit, metabolic acidosis, alkalosis, and respiratory acidosis and alkalosis. Fluid and electrolyte balance, we look at edema, dehydration, acidosis, alkalosis, preparations, and administration of intravenous therapy. Causes of fluid electrolyte imbalance, that's unit 2, acidosis and alkalosis. Features known as the clinical manifestations of dehydration, overhydration, electrolyte imbalance, and acidosis and alkalosis. Compensatory mechanisms associated with isotonic and hypertonic dehydration. Risk factors for dehydration. Unit 4, we look at interventions for client, that is the nursing care. Clients with fluid electrolyte imbalances, client history, physical examination, skin color, moisture tagger, weight, urine output, vital signs, breath sounds, muscles weakness, and at the CNS, you look at the mental status, hyperplasia, tetany, shivostic sign, triosol sign, cardiovascular system, you look at arrhythmias or dysrhythmias, and decreased cardiac output. So the diagnostic investigations that we do look at the serum levels, urine test, pH, specific gravity, blood urea, nitrogen, and creatinine, arterial blood gas, and iron gaps. They will look at hemoglobin and hematocrit. For the nursing care, we look at the oral rehydration therapy used to treat dehydration or deficits, therapeutic diet, blood gas interpretation, semi-Fowler's position, respiratory, oxygen 10, cough, deep breath, incentric spirometry, oral hygiene and infusing therapy, then health teachings. Then under the infusing therapy, we go into details to look at the infusion systems, containers and administration sets, needleless systems, that's the cannula, infusion regulation devices, types of infusing therapy. We look at intravenous therapy, peripheral description devices, that is short-term versus long-term, dual catheters, that is patient receiving just a day-old infusions and those receiving over 1 month infusions. Central intravenous therapy devices, non-tunnel central venous system devices, implanted port, common intravenous maintenance procedures, complications of intravenous therapy, arterial therapy, description devices and complications, intraperitoneal therapy, description device and complications. So we have various intravenous therapies. So we have those going to the intraperitoneal cavity. So we have intravenous peritoneal therapy, subcutaneous therapy. We have those going through the intraosseous, intrathecal, epidural. So those therapies are all going to be discussed and their complications. So unit 8, we look at introduction, of course, peptic ulcer. So we move from fluid and electrolyte imbalance, we go to a different system, which is gastrointestinal system, GIT. Under the GIT, we look at peptic ulcer. We look at the peptic ulcer diseases, gastric esophageal reflux disease known as GERD. Just recently, a patient called me and it was an emergency around 12 midnight. She was under distress, experiencing severe GERD, and she needed to be intervened. Otherwise, there was going to be a disaster. It worried a lot of patients. Achalasia, unit 9, intestinal obstruction. Under that, you look at Zolling-Ellison syndrome, irritable bowel diseases. Unit 10, we look at appendicitis, peritonitis, ulcerative colitis, Crohn's diseases, and hemorrhoids. Unit 11, look at diverticulitis, anal fissure, fistula in ano, malabsorption syndrome. Unit 12, peptic hepatitis, that is liver cirrhosis, hepatocellular failure, and hepatic coma. Unit 13, we look at cancer of the liver, liver transplantation, fatty liver, cholecystitis, and pancreatitis. So we know where the midterm was set in, then we can do our midterms. Then we move on to the endocrine system, where we look at the hyperpituitarism and hyperpituitarism, diabetes insipidus syndrome of inappropriate antidiuretic hormone, diabetes mellitus. They will look at unit 15, Anderson's diseases versus Cushing's syndrome, adrenal gland hypofunction. Unit 16, look at renal function or renal failure and nephrosclerosis. Unit 17, look at nursing care of patient undergoing peritoneal dialysis, diabetic nephropathy. Unit 18, we look at diabetic foot, nursing care of a patient or diabetic patient undergoing surgery, orchidopexy and orchidectomy. Then we look at diabetic ketoacidosis, DKA. Evaluation is 30-70, 30 for continuous assessment and 70 for end of semester. So you are expected to go through this busy content, very voluminous content. So no room for complacency, no room for absenteeism, no room for excuses. You have a whole Herculean task to undergo. So look at, these are the materials that you can lay your hands and read. We will send you these materials at the end of the day for you to consider them. Okay, so any question with regards to whatever content we have gone through right now? So it's a whole voluminous, a very busy content. Yes, it shall be well. I like that. Sandra Boatin say it as well. And yeah, easy. Tighten your seatbelt, it shall be well. Very soon it shall be well. Yes, I like that. And Piaget says it as well. Inshallah, it shall be well. Yes, Caleb, it shall be well. Yes, Caleb. Yeah, Caleb raised the hand. Let me hear you, my brother.
Yeah. Sir, I'm Caleb. I wanted to ask, like, our the examination. Are we going to write objectives, or we missed the theory together? Hello, sir.
So it is too early to ask these questions from Caleb. Anyway, you're going to have multiple choice question for the midterm, and the end of semester will be mixture of multiple choice questions and other questions as well. For the midterm, it's going to be multiple choice questions. So far, that is how it's going to be. But it's too premature to ask these ones. Let's go through. This is what I hate. I was going to talk to you about the do's and don'ts of the class. The do's and the don'ts. Yes, the mandate has been given to the rep to control these sounds. Otherwise, they will disturb me and they cannot allow me to continue. I have to go and look for the person and mute the person. So the class rep is mandated to do some of these activities for me so I can concentrate and deliver. Anybody who is misbehaving, mute the person. Mute the person. Okay. So the first thing we don't want to know or we don't want to do is joining and failing to mute your microphone. So your background noise. Yes, you'll be surprised. Yeah, whatever we are saying, some people don't even understand it at all. They don't care. They just ignore the rules and they do whatever they want. You will see a lot of different people's behavior, and that is why we have to exercise a lot of constraint. So much constraint. We need to exercise that to be able to handle you. Whatever you have said they shouldn't do, they will do it. They will do it. The rep say he doesn't have access to mute the class. I think then I will tell the IT people. You say I should increase my volume. It's 93, so it's 100 now. My volume is 100 now. So I don't know. Is it still the same? Let me hear from you, class. Can't you hear my voice?
Please, we can hear you.
Very good. Very good. But they say you have access to mute those who are talking. Please, don't you have access? The person who muted the one who was talking. Let me know.
I said it's me, Caleb. I did. I muted. I have access.
Very good. So you control those who make noise. Okay.
Okay.
Yes. If the person continue to make noise, the best thing is to remove the person from the class for that particular lecture. Okay. So once you remove him from the class, next time he will not make that noise again.
Okay.
So you give him the benefit of the doubt. You want him or her, then you remove him from the class. That's all. Okay. So any questions so far from what we have done? I just want to hear from you. Yes. Any questions so far? Yes, class. I'm still waiting for you. Yes, somebody raised the hand. Yes. Please, let's hear you. One hand, two people have raised. That is Rebecca and Mark. Let's hear you.
Good afternoon.
Good afternoon.
Please, mine is not a question. I only want to read with you so that when you start the class, you take your time because when you were reading very fast. So please, when you start lecturing, you can really take your time fast and understand.
Yeah, it's because I was going through the course content. Yes, I don't teach like that. It's because for the course content, I will send it to you and it shouldn't take our time. It's because of the course content I was taking you through. You know, this course content should have been discussed last week when I was at a lecturer's funeral. One of our lecturers died and we're having the funeral last week. So we wanted to do this quickly and then get on board. Yes.
Okay. Thank
Peter. You. Yes, thank you. Peter.
Yes, sir. Yeah, good afternoon. Good afternoon,
Good afternoon.
sir.
Good afternoon.
Yeah, please, my concern is This one is a plea. At times, it's not our fault. The network, it will go off, and after, like, you want to join again, you can't join. So in this case, it's not our fault. So if I'll plead, if something happen, they should allow us to join, please.
Hello, please. The person who was speaking, please, can you come on again? I was talking to the HOD. Please let me hear you. The one who was talking, yes.
Yeah.
The attention wasn't there. The HOD called at that time. That was Peter.
Sir.
Akable.
Yes, sir. Yes,
Yes.
sir. Sir, please, I was saying, like, this one is a plea. At times we'll be joining the lectures and the network can go off anytime. And later, when it comes, you want to join, like, you find it difficult to join. And I'm saying, I'm pleading, if when something happens, we should pardon us so that we can join.
No, the issue is that because you are new here, it is from the IT. You know, these links are all created by the IT team. And any concerns, we should link it to the IT. You pass this concern through your classroom, you will let the IT guys know of it so that they can rectify them for you. So we don't have a full control over the IT systems. It's the IT unit who handles all these, okay? So don't worry, your plea is considered, but pass through the class rep, Caleb, and Caleb will notify the IT team for them to rectify it for you, okay? Yes.
Hello, sir.
Yes.
Sir, good afternoon.
Good afternoon.
So please, my concern is looking at the voluminous nature of this course. This is a plea that, if possible, we can get some of the slides before time so that we can prepare ourselves even before the lectures, so that we can get ourselves more abreast with the conditions. And also, I wanted to know if options will be made for group presentations. Thank you very much.
Yes, that one, it is clear. You have to present for us to know your abilities to speak, your ability to prepare notes and deliver. That is part of the training. That you need to deliver messages to audience and know how to present your messages. Presentation is very, very key. However, the reason why some of the lecturers don't make slides ahead of time is some people get the slide and they don't attend lectures. That is our experience over the period. Our observation shows that most of the students, when you send a slide to them, they get a slide, they think they are okay. They don't care whether to attend lectures, and they think the slides are okay for them. But the explanation, sometimes I will present just a skeleton of the slide, but the explanation is so voluminous such that most of the questions are set from the explanations that I give. You will see it very soon when I start with fluid electrolyte imbalance. I will just show you a PowerPoint slide, just a slide, and the explanation will take about 30 minutes. That is how it is. So don't think that the slide is okay for you, and therefore you will not attend lectures. You must compulsory, you must be compelled to come for lectures, even though you have the slide. The slide is not just a skeleton. The inside and detailed explanation is coming from the lecturer, which you need to understand and listen. So all the concerns, please, the IT issues, channel them through the rep. They will get the IT unit's attention to address them. Thank you. Yes, any more concerns? Any more concerns? Before I move on,
Hello, sir.
yes.
I want to make a plea that in the unlikely event that a lecture will delay by, let's say, 30 minutes to an hour, if it is possible that the class will be informed ahead of schedule. Because sometimes we log in and then we have to wait for sometimes up to an hour before the lecturer comes on board. It burns our data, And then, so in short, that's just the plea I want to make. And
Okay.
also believe that if it is possible, though sometimes it is with outside of your control, but make it possible to always also come to the class on time. Thank you.
Okay. Your comment is well taken. However, I don't know when you started lectures. Maybe you started last week, and last week I gave the message to. I always communicate to your rep. I can't speak for other lecturers, but last week when you were supposed to start lectures, and I sent a message to your rep ahead of time that I am at a colleague's funeral, a colleague lecturer's funeral, and it's not possible I can lecture at the funeral grounds. It was clear. So mostly if I will not come for lectures, I'll give the message ahead of time, even the day before. So you don't even join at all. I'm speaking for myself. I don't speak for other lecturers. I don't know what goes on there. I don't know if any lecturer had let you be linking or connected to the link for over an hour without telling you anything. I don't know. But what I know is what I'm saying. Just last week, a colleague's funeral, it wasn't possible to teach. When a colleague is late in state, and we needed to give him the last respect. For today, we started chatting since yesterday. I made him aware that today we are meeting, and lo and behold, we are connected just on time. So I can only speak for myself, and I don't think I will let students come and connect and wait their data for almost 30 minutes, an hour without they started telling them anything. I don't do that. So that one can be for other lecturers, but or non-law. That is what I do. Those who have done a little bit of anatomy, muscles behave or non-law. Either I come and lecture and go, or I don't come at all, which I always give you information ahead of time. So what you have said, well noted, but that may be for other lecturers and not for medical nursing lecturer. So, or medical nursing instructors. So it's well taken though, but mine is straightforward. I come and deliver and go on time. If there's anything I can't come, I'll give you an even assignment to even occupy you at that time to clear those assignments. And that is how I go on with my teachings. So that is it. Any other concerns? Yes, any other concerns? Okay, so if there is no concern, then I think we can hit the ball or the ground running, set the ball rolling. Okay, so under the fluid electrolyte imbalance, you are expected to know the various fluid compartments, how fluids are distributed among the body's compartments. And if you look at the diagram there, I have pasted here or shown here a woman and then a man. The woman has a blood component, which are two here. We have the fluid portion and the solid portion. The solid portions are the cells, and the cells are mainly the white cells, the red cells, and the platelets. For the two, the red portion contains the fluid, which in other words called the plasma, and the cells or the solids are the red, white, and the platelets. If you look at the woman on the left side, the woman has about 45% solid as a component of blood, and the fluid portion, which is the plasma, constitute about 55% of the blood volume. Compare this to a man who has about 40% of the cells, and the fluid portion or the plasma, the man constitute about 60% of the fluid. So in that way, we could say and conclude that the man has more plasma than the woman in terms of plasma volume. The man has more than the woman. That is why they say the men have more blood than the woman counterpart. So if you check about the HB parameters, the man's HB can go about 16.5 to 17, but the woman can only go up to 16 or sometimes 15 point something. And the minimum border for a woman for hemoglobin is around 12 or so for the minimum border, but the man is about 12.5 or 13 at the minimum border. So the man has more of the hemoglobin than the woman counterpart. And this is because of the amount of the plasma the man has in his body compared to the woman. So if you take the blood component, this is how it is. Now, the body has two main components, and the major two main components here, we have two. The one is the extracellular fluid, and the other one is the intracellular fluid. So if I move from this slide and maybe show you, yes, about this pie chart. Okay. Taking this to be the whole body compartment. The intracellular fluid constitute about 65% volume of the body fluids that we have. Inside the cell is the intracellular. Any fluid outside the cell constitute the extracellular fluid. Please make sure you understand this phenomenon before we move on. Inside the cell composed of all fluid, and that is 65%. Any fluid outside the cell constitute 35%. When I mean extracellular fluid, or I talk about extracellular fluid, I mean fluid in between the cells. Let me see if I can get you a cell. Okay, so let's take into consideration these are cells. These are cells. So from cell 1 to cell 2, there are fluids in between the cell. And that is the interstitial. So fluid found in between the cells are called interstitial fluid. They are outside the cell. So it means one component of extracellular fluid is called interstitial fluid. Interstitial fluid. It is outside the cell, but it is found in between the two cells. Now, looking at the spaces in between the cells lies the circulatory system, where we have the blood vessels, the lymphatic capillaries, the blood capillaries, all that. So they all are also part of the extracellular fluid because they are found outside the cell. So in short, all the fluid that are outside the cell and found within the blood vessels are called intravascular fluid. Intravascular fluid are fluid found within the blood vessels. So extracellular fluid have now two: interstitial fluid and intravascular fluid constitute extracellular fluid. Now, the third component of extracellular fluid is called transcellular. Transcellular fluid constitute other smaller fluids found within the membranes and the small cavities. Talking about the joint cavity, talking about the cerebrospinal fluid, talking about the saliva, talking about the tears that we shed, talking about the mucous membrane. All the fluid that are found within these small spaces constitute what is called transcellular fluid. They are also part of the extracellular fluid. So when you talk about the extracellular fluid, we are talking about three major things: the interstitial fluid, intravascular fluid, and transcellular fluid. They constitute extracellular fluid. We will look at the percentages later. I just want you to appreciate the divisions now. So I just want to sum it up. The cell as it is, the human cell, has two major components. We have the intracellular inside the cell. Look at the bigger cell there. The bigger cell inside is the fluid found inside is the intracellular fluid. That constitutes about 65% volume of the blood. Then outside the cell constitute or forms the extracellular fluid. However, the extracellular fluid, we have three major things under the extracellular fluid. We have the interstitial fluid, intravascular fluid, and transcellular fluid. That's combined to form the extracellular fluid. Now, these are the compositions. From book to book, you can have differences, but I like to present this pie chart because it gives a clear pictorial evidence. The intracellular fluid, which is fluid found within the cell, is the greatest. In terms of fractions, it constitutes 2/3. Put it at the back of your mind. In terms of fractions, intracellular fluid constitutes 2/3 of the total body fluid. Now, the extracellular fluid takes the rest of the fraction, which is if you have intracellular taking 2/3, then the extracellular will take how many fraction? Simple mathematics. It will take how many? 1/3. Yes, 1/3. So that's the percentage. I'm talking about the fraction. So the fraction is the 2/3, and the percentage will translate into 65%. And the extracellular fraction will take 1/3. Percentage will give you 35%. Out of the 35%, the interstitial fluid found in between the cells, constitutes 25% of the extracellular fluid. 25%. Then the plasma, which is the intravascular, takes 8%. And the next 2%, which is the transcellular fluid, will take the rest. So these are how fluids are distributed among the body compartment. It is very, very key to know that, so that you know how fluid move in and out of the body. When fluids start moving, this is another presentation from another book, the total body water, intracellular fluid constitute, he has put it to be 63% of the intracellular. The rest outside the cell is the extracellular fluid. And the next is the interstitial fluid, which constitute the 25, the plasma taking the 8, then the rest, the lymphatic, take the transcellular. So all of those are extracellular fluid. As rep, please do your work. Some people are making noise at the background. They are just making mockery, laughing, and they are just new. So just mute them and talk to them later. Yeah, we don't joke.
Say, I've been removed from it too.
You have been
removed from the co-host.
Who removed you? Hey, Rebecca Yabua and Kwaku Kunadu. Rebecca Yabua Kwaku Kunadu. I'm going to remove you from the class if you continue to disturb. You are just wasting your time. Then you don't need even to join. This was what I was talking about. Look at what they are doing. Be serious. I'm telling you. If you are ready for the lecture, you avoid all other distractions and disturbances. You haven't seen anything. Yes. They don't care. They have just connected to be part, but they are not listening to the lecture. They are not. They wouldn't have been chatting. So you see a man and a woman chatting, talking about something different outside the lecture. You haven't seen anything yet. and all the announcement or whatever we are doing, they will never take it serious because they think they are not in the classroom, so you can control them. That is the behavior of some of you, not all of you, excuse me. Very sorry, not all of you. But few among you, you are never serious. You are never serious. I am explaining very important point that will help you to understand subsequent lecture. And stupidity is full of you. Those people who are making noise, you are the one I'm talking to. Nothing will tell you that you have a gap between diploma and BSc. So you need to bridge that gap. Nothing tells you. No sense. And as you communicate and chat, as the lecture goes on, how do you pick the points and the understanding to move ahead? I started giving you the do's and then the don'ts, but they will never obey. I will continue to mark those names. You know, I can know all that. If you keep on disturbing, I take care of your particulars. Lectures are going on. You have joined. Nothing tells you that, look, whenever you join the lecture, it means you are in a classroom. Whatever conversation that you do is that you are in a class and you are talking. Everybody hears you. If you don't know about the online learning, that is how it is. But you had the opportunity to mute your microphone and listen to the lecture. That not enter into the lecture period. So the two people, Kunadu and Ko, I have taken their notice.
Kunadu is me. I was telling the lady to stop, to mute.
So it was the lady who was talking at the background, right?
Yeah, so Kunadu is me,
Caleb.
So I was yes. telling her to mute.
Sure.
Kunadu is me. So I was telling her to mute.
Sure. So later you give me the lady's name and then her information.
Okay, sir.
They are the same people who will come and chat to you, so I don't understand. But if you keep on doing this, how do you expect to understand? How? When you do this, then you go, some of the lecturers don't have that temperament. Then they talk to you anyhow, and then some of you go and then you go and report. Meanwhile, it is some of you who put the lecturers to the tight corner to say some of those things that they do. We may have the patience, but some lecturers will not have the patience at all. Okay, so the definition here of FVD, so we start with the fluid volume. As you see, FVD is fluid volume deficit. How does it occur? So it occurs when water and electrolytes are lost in the same proportion as they exist in the normal body. So in the same proportion means that the ratio of serum electrolytes to water remains the same. So this tells you that if you have 100 mils of water inside the body and you have 100 grams of salt inside the body, if you are talking about FVD, fluid volume deficit, if it is describing the loss as the same proportion as they exist, means that if you lose 20 grams of salt, you lose 20 mils of water. If you lose 50 grams of salt, you lose 50 mils of water. So at the end of the day, the amount of water in the solute you have lost will reflect on the amount of water and solute remaining in the container or in the body. So at the end of the day, the ratio of serum electrolytes to water remains the same. Equal proportions of solute and then the fluids are lost in the same proportion. So FVD is decrease in intravascular. So I took the opportunity to explain intravascular because one of you will call me that say, I don't understand intravascular. And now I have explained to you what intravascular is. So when I talk about decrease in intravascular, I'm talking about decrease the plasma volume within the blood vessels. So if you talk about the fluid volume deficit, first, the deficit is seen within the intravascular compartment. And then later, it affects the interstitial fluid, which means we are still talking about the extracellular fluid. Because the extracellular fluid composes the intravascular, interstitial, and transcellular. But when you talk about FVD, it's a decrease in intravascular and interstitial. They constitute the majority of the fluid for the extracellular fluid. So there's first decrease in extracellular fluid, which forms intravascular interstitial. And when this decrease occurs, it's a common and serious fluid imbalance. And if you don't intervene on time, it may lead to fluid volume loss, and we call it hypovolemia. Hypovolemia can lead to shock, can lead to collapse, and the person can go into permanent shock. You needed to intervene on time. And this LVD can lead to cellular fluid loss. When the fluid is lost or shifted from the extracellular volume and you don't intervene, then when the extracellular fluid is lost and become too deficient, then it starts pulling from the intracellular. That is where fluid starts shifting from the cells to the vascular space to restore fluid balance. So first, the loss is seen at the extracellular compartment. If you don't intervene, send the child to hospital, send the patient to hospital for them to restore fluid balance. Then if the vomiting or the diarrhea continues, then the shift now moves from the extracellular to intracellular, inside the cell, and start moving fluid from inside the cell to replace which has been lost from outside the cell. So fluid first shifts from the extracellular space, then later it moves into the intracellular and pull water from the inside the cell to replace what has been lost from the extracellular compartment. So we say that it can lead to cellular fluid loss owing to fluid shifting from the cells to the vascular fluid space to restore fluid balance. And when this happens, we have two forms of, or two major types of FVD. Two major types. We have the hyperosmolar fluid volume deficit and the isoosmolar fluid volume deficit. The hyperosmolar is mean that you have lost more fluid than the cells. So fluid loss is greater than the solutes or the cell. Then the isoosmolar fluid volume deficit, in which case there's equal proportion of fluid and solute are lost in the same ratio. So I can have two containers. And the first container, I can have 80% of solute, talking about salt. We are in fluid volume deficit, talking about solute, we are talking about salt. 80% of salt and 20% of fluid. So the 20% of fluid will be at the top, and 80% will be just below the fluid because the solutes are heavier than the water, so they will be below it. And that will experience that we have solute that constitute 80%, and that makes it hyperosmolar because we have 20% of fluid and 80% of solute, which means we have lost more fluid than solute. More fluid than solute. So in the container of 100, we have only 20 mils or 20% and 80% of solute. Then the next one is the isoosmolar, where you lose 20 mils of solute, and then you lose 20 mils. 20 grams of solute is lost, then 20 mils of fluid is also lost. So at the end of the day, we have 80, 80. 50 mils of water or fluid is lost, then 50 grams of solute is lost. So at the end of the day, what is left behind the salt or the container is 50-50. We call it isoosmolar. Causes of fluid volume losses or fluid volume deficit. Causes. You can't say vomiting. So we say serious or severe vomiting. Severe gastrointestinal suction. The patient mistakenly takes poisonous substances like kerosene, like parazone, and you want to prevent this poisonous substance from being absorbed. Then you go to the hospital, they suck. They use the suction machine, and then they suck. With the NG tube, they suck. So they suck the abnormal or the poisonous substances, preventing it from being absorbed. And by so they suck the fluid from the GIT. It can cause a lot of fluid loss. Severe sweating under the scorching sun, like the one we are seeing today. If you are standing under this scorching sun and working, you sweat and you lose fluids. Severe diarrhea, you are losing fluids. So these activities will lead to fluid volume deficits. Decreased intake, as in the presence of nausea or inability to gain access to fluids. So there are differences. Somebody has the appetite for water, but because he is walking along under the Libya border, he doesn't have access to water. So here is inability to gain access to fluids can cause severe fluid volume deficit. The other person has water abundant, available around him, but because of nausea and vomiting, he doesn't have the appetite to drink. It will still going to affect the total fluid volume and can lead to fluid volume deficits. There are situations where fluid shift into body cavities. We call it stasis, where fluid move from vascular system to other body spaces. That is with edema formation in veins or ascites with the liver dysfunction can also produce FVD because fluid move and accumulate within body cavities. And this can lead to FVD, fluid volume deficit. So the pathophysiology is very simple, as the changes related to FVD are usually related to changes in sodium levels. The moment we talk about FVD, we are referring to sodium level. In fact, sodium is a major influencer of fluid balance. When we talk about fluid balance, we are talking about sodium level. So sodium has a major influence on water retention and water loss. As we speak, prepare a food, very sumptuous food, and put in a lot of salt. The moment you take in that food, time yourself, within 10 to 15 minutes, you start experiencing severe thirst. This is physiological response to excessive sodium that you have taken, and it's calling for salt to balance the amount of sodium and then the water inside the body. So sodium is a major influencer when we talk about fluid balance. So it's very good. It influences water retention and water loss. So serum sodium concentration is increased with FVD due to insufficient intake or massive water loss. So the moment you experience FVD, either you are not taking enough because you are having nausea, or you are not taking enough because you don't have water around you. This can lead to water loss, FVD, severe FVD. And at that point, the amount of sodium inside the body will be greater than the amount of water inside the body. So the increased serum concentration causes FVD. If you have a question, please write it down. When I'm teaching, you don't intervene with questions. Write your questions down. I'll give you maximum time to ask so I can flow. When I pause, I call for questions. Then you bring in your questions. We dilute them, we explain them for you to understand. So the increased sodium concentration causes FVD by shifting water from the cells to the vascular space to decrease the hyperosmolar that occurs with water loss. This shift causes cells to shrink and cellular dehydration to occur. So once LVD occurs, as I said earlier, the water is first shifted from extracellular space, then later it draws water from inside the cell to replace the one that was moved from the extracellular. So fluids are always shifted from intracellular to extracellular compartment to balance the fluid in the extracellular space. So always shift of fluid occurs and it starts from the cells, it starts from outside. But when the extracellular fluid is lost, then it goes inside the cell, intracellular. Move water from intracellular to replace what was lost from the extracellular. So anytime there's hyperosmolar at the extracellular space, water is shifted from the cells to replace the hyperosmolar so that it will balance the hyperosmolar. And once water starts moving or fluid starts moving from the cells, this can cause, or this shift can cause the cell to shrink. And this is what we call cellular dehydration. When the patient complains to you at the consulting room that I'm feeling pulse and crampy within my body. Doctor, I feel crampy, I feel pulse, and that is serious cellular dehydration. So with serious LVD, if it continues and you don't intervene, there's vascular collapse and shock can occur because as water moves out of the cell, the brain also loses fluids, and at a point you go into a state of severe shock. Hypovolemia can cause collapse and shock. And the clinical manifestations are due to changes in the cerebral cells, that is the brain cells. And this is how fluid are lost. The rich fluid are shifted from the cells. If LVD develops rapidly, meaning that you lose fluid at a faster rate, the manifestations are more severe. If you lose fluid at a rapid rate, the manifestations are severe, and this can lead to severe brain shrinkage during water deficit. And this may cause vascular damage and intracranial hemorrhage. If fluid is shifted rapidly, it can cause the brain cells to shrink, and this can cause severe hemorrhagic stroke can occur. If it rapidly shifts from the brain. Been talking about severe diarrhea and vomiting, severe bleeding, all can cause one to lose fluids. You can lose fluid when you something cuts through the blood vessels and you are bleeding profusely. When LVD occurs slowly, then the brain has time to adapt. If the LVD occurs rapidly, the brain shrinkage and other severe can occur. Damage to the capillaries can occur. When it occurs slowly, the brain adapts to the increased intracellular osmolar by producing extra intracellular particles called adiogenic osmosis, which prevent large amount of water from leaving the cell. So if fluid loss is gradual, is slow, then the brain adapts by producing what is called adiogenic osmosis. When the brain loses fluid gradually, they produce adiogenic osmosis, and the adiogenic osmosis reduces the amount of fluid loss. They prevent large amount of water from leaving the cell. So you don't get any complications, you don't get any serious signs and symptoms because the body can adapt due to the presence of adiogenic osmosis. They reduce the rate at which fluid leave the cells and you losing the fluids. They put brakes on the fluid loss and the body adapts and can maintain. So clinical manifestations here, if the development of fluid loss is rapid, it can be mild, moderate, or severe. Any amount of fluid loss falls within these three categories. Either the fluid loss is mild in terms of grading, whether fluid loss is moderate or the fluid loss is severe, depend on the degree of fluid loss. It will lead to acute weight loss. If it is rapid and severe, it leads to acute weight loss. The amount of water inside the body determines the amount of blood inside the circulatory system and determines the amount of weight that you have. If you lose fluids, you lose blood and you lose weight. That is how you relate it. The amount of fluid inside the body will determine the amount of blood in circulation. It determines the amount of weight that you have. If by any circumstances you lose so much fluid through diarrhea, through vomiting, through excessive sweating, through inability to gain access of water to drink, through nausea and vomiting, whatever the case may be, through bleeding, it will affect the blood volume and consequently affect the body weight. Decreased skin turgor. If you lift the skin cannot be lifted. It just falls and remain high. I will show you a picture on that. Decreased skin turgor. You pull the skin remains at the top. It doesn't fall flat. It tells you the amount of fluid that has been lost from the skin. The skin becomes inelastic, wrinkled, dehydrated, dry, mucous membrane. If you put urine out there, you would experience what is called oliguria, scanty urine, concentrated urine, becoming too amber in color, yellowish. That tells you that the body's urine is too concentrated. You need to drink water to dilute it. And because water or fluid loss has affected the blood volume, blood in circulation has gone down. Amount of blood reaching the brain has gone down. So you experience what is called postural hypotension, changing posture, and you start experiencing dizziness. Postural hypotension. The brain is inadequately perfused because fluid loss has affected the blood volume. Blood is not reaching the brains. You experience postural hypotension. You have lost fluid. It has affected the blood volume, and therefore the blood is compensating. Amount of blood reaching the heart is woefully inadequate. So when the heart pumps the blood, some body part do not get enough supply. So the positive feedback mechanism is that heart should beat at a faster rate in order to compensate for the loss. So you have weak rapid pulse from the heartbeat as a means of compensating the blood in circulation. How do you diagnose? Investigations to run. Blood, urea, nitrogen, they are the waste in the body. The kidney produces the waste. The liver produces the waste, the kidney is supposed to clear the waste. So the liver is supposed to metabolize and generate these waste, urea, nitrogen, and creatinine from protein metabolism. It is the work of the kidney to flush this waste through urine. But if the body is dehydrated, how can the kidney clear this waste? It needs enough volume of water to expand the blood volume so it can produce enough urine. And as you produce the urine, it clears the waste. So in terms of LVD, the amount and the quantity of BUE, the level of blood urea nitrogen in the serum in the blood increases. The concentration is high because it looks like a dry season with a choked gutter. When rain falls, the gutter is washed away. But in the dry season, as much as remain the dry season, the gutter remains choked, full of rubbish. That is the nature of the dehydrated body. It's full of waste. Hematocrit level is greater than normal as the red blood cells become suspended in the decreased plasma volume. Here we are matching the cells and the plasma. The amount of blood cells that we can have is calculated to be hematocrit. talking about the cells alone. If you go to the pediatric ward, if you are talking about the hemoglobin level to transfuse a child, we don't take hemoglobin, we take hematocrit. Just take a blood full of blood, put it in a capillary, microcapillary, put them on the centrifuge machine, set the centrifuge machine in motion for some few minutes. At the end of the day, the microcapillary separates the plasma from the cells. The amount of cells is calculated to be the hematocrit. If the hematocrit levels are too low, it means that the child will need packed cell transfusion. If the amount of hematocrit is high, it means the child can receive a whole blood. Because if the amount of hematocrit is too high, it means that the cells are okay, we have very few amount of plasma. So the hematocrit is the blood cell. If it is high, it means it is more than the plasma. You don't need the packed cells. But if the hematocrit level, which is the blood cells, are low, the plasma volume is already high. And you cannot transfuse a whole blood which already have high volume of plasma. The child will end up getting edematous with facial edema and peritoneal edema. You have more fluid than cells, and this is not acceptable. So anytime you want to transfuse a child at the pediatric unit, the best diagnostic tool is to check the hematocrit level to know the actual cells in circulation. And that will determine whether the child will need a whole blood or packed cells. And in LVD, you have a lot of blood cells suspended in a very limited amount of plasma volume. How do you manage LVD? Several factors are considered here. Take into consideration whether there's fever, then treat the fever, because fever can also lead to dehydration. When the child runs fever for some time, it can cause severe dehydration. So make sure there's no underlying fever. If the deficit is not severe, then we take the oral route. We prefer the oral route. And any amount of water the patient can take, give it orally, provided the patient is not vomiting. Can range from so many of the oral fluids that we take. Coconut water, which is kubensuo. The porridge water, rice water, dokonasinsuo, sobolo, pito, unfermented one. A whole lot of drinks, locally made, available. ORS, you can prepare ORS. Take into consideration if this occurs in a village where you don't have access to ORS. Take some salt, take some sugar, calculate it and prepare the homemade ORS in an attempt to resuscitate the person. However, if fluid losses are acute and severe, then the oral route is not preferred, but we prefer the intravenous route because of the nature you are losing fluids. And when we go to the intravenous route, we are talking about isotonic electrolyte solutions. Here we are looking at the Ringer's lactate, that is 0.9% sodium chloride. So either we take Ringer's lactate or normal saline. The normal saline is 0.9% sodium chloride. So anytime you want to expand the blood volume, anytime a patient is losing fluids through diarrhea and vomiting, these two fluids are considered. Ringer's lactate and 0.9 sodium chloride. They are frequently used to treat the hypotensive patient with LVD. So anytime a patient walks to you and they complain and then the diagnosis that severe dehydration, these two fluids are considered. Don't use only sodium chloride. Combine the Ringer's lactate and then the 0.9 sodium chloride. Because such fluids expand the blood volume, and you need blood expanders because what has been created is hypovolemia. Therefore, you need blood expanders. So as you put on the fluids, you keep monitoring the vital signs. The moment the patient becomes normotensive, meaning that the vital signs are now stable, the patient is no more hypotensive, the blood heart is no more compensating, then the patient is in a state of normotensive. Then you change all the infusion. Listen carefully. After you have achieved normotensive, then you change the infusion and put on hypotonic electrolyte solution. And that is 0.45% sodium chloride. There's a reason for this. 0.45% sodium chloride is a hypotensive fluid. And we put on this particular fluid to provide both electrolyte and free water for renal excretion of metabolic waste. It is known that during severe dehydration, there was so much waste that was kept within the body's circulatory system. And therefore, when the patient becomes well hydrated, then you need to put on hypotonic solution to wash away the waste from the body so that the waste can be excreted through urine production. And that can be possible when you put hypotonic or 0.45% sodium chloride. Gloria's iPhone. Gloria, mute your microphone. Please, we don't like any disturbances. So let's move on to this slide where we have containers to explain in terms of fluid set. So we have two containers. The one at the top on your left. There are two containers on your left at the top. There's one container with a very small amount of fluid, but the cells in that container is a lot. So in that aspect, there's a lot of concentration, but the fluid there is too low. Let's look at the other container. It has also a lot of fluid, but the cells are low. So in terms of concentration, the one with few solutes and more water has low concentration. So if you are defining osmosis, osmosis defined as either in terms of fluid movement or in terms of solute movement. So if I define in terms of fluid movement, then I will talk about movement of fluid from a lower or a region of lower concentration to a region of higher concentration across a semi-permeable membrane. And that is what the first container explains. The container has two compartments. One has a lower concentration and has a higher concentration. But if you are describing movement of fluid in terms of osmosis, then fluid will move from region of low concentration to a region of higher concentration across a semi-permeable membrane. This will continue until the container becomes, or the concentration becomes okay, until the fluid shift stops. So if you look at the container at the top on your right, you will see that now fluid has been shifted to the extent that it has balanced the solute that was contained in that container. Now, the container that was half full is now full. So fluid has filled the entire container, balancing the amount of solute in that container. And that balances the concentration in both containers. That explains movement of fluid by osmosis. Let us look at the container below. That explains osmosis in terms of solute movement. Now, in terms of solute movement, the water level are the same on the right, on the left side, but the solute on one side, the first, is more than the other. So in terms of solute movement, solute will always move from a region of higher concentration to a region of lower concentration across the semi-permeable membrane to balance the concentration. So if you look at the container on my right, the solute has moved and it has now balanced the two containers. Now the two containers has equal solutes. These two or four containers explains how osmosis is defined in terms of movement of fluid or solid. If the patient with severe LVD is oliguric, which means that scanty urine is being produced, it has to be determined whether the decrease in renal function as a result of the reduced blood flow, secondary to fluid volume, pre-renal azotemia, or more seriously to acute tubular necrosis due to prolonged LVD. Prompt treatment of LVD is very important to prevent renal damage. Anytime you see a patient with LVD and is producing scanty urine, take it to be emergency. And think about these two. Is reduced urinal production has affected the kidney cells, and therefore the patient is experiencing tubular necrosis because dehydration, the first organ we look at is the kidney. Is the kidney intact? Has the kidney been affected? So if you experience LVD for a long time, the kidney may undergo tubular necrosis, acute tubular necrosis, and that can affect the amount of urine produced, and therefore the oliguria. Or the oliguria you are experiencing is simply as a result of LVD, not enough blood is reaching the kidney, and therefore not enough urine is produced. So I have told you, if you don't take enough water, the blood volume may fall low, and the amount of blood to the kidney also reduces. Therefore, the amount of urine pass also reduces. So think about the two. If LVD occurs and there's presence of oliguria, has it affected the kidney cells, or it has only affected the blood volume, and therefore you are producing scanty urine? And you must make every effort to treat promptly LVD to prevent renal damage. Before the nursing process, let me take some few minutes to address your concerns, contributions, and your questions before I go through the nursing process. I saw some hands raised up, and let me see those hands, and let's welcome your questions. Sarah, let's hear you. And so Sarah will
Hello.
talk.
Okay. Please, I have three questions. The first one is sodium the only electrolyte that can cause FVD? Because I know that in our bodies we have a lot of chemicals, or should I call them electrolytes? So should we always associate dehydration or FVD to just sodium? And why?
Is that your question? Is that all?
Yeah. Should I go on with the other two?
Yes.
Okay. The second one is you spoke about ideal osmosis. Please, am I right?
Hydrogenic osmosis.
Yes, hydrogenic osmosis. Please, I want to know exactly how they work.
They prevent water from shifting the cells. They keep bricks on the water. I explained that. Were you there?
Yes, I was.
They put bricks on the water loss, thereby reducing the dehydration process.
Okay. And please,
well
what is it possible for a hypertensive client to be dehydrated? And if it is it advisable to have fluid resuscitation?
It is possible for every patient to be dehydrated. Every patient to be dehydrated. Every patient can be dehydrated. And you have to know the underlying condition and how to intervene. You need to run, listen to the history, know the underlying condition, know how to intervene.
Okay.
So the hypertensive patient may be dehydrated, but at a point, a hypertensive patient may be receiving sodium chloride, normal saline, and Renges because of the dehydration. To resuscitate him until he gets to the normotensive state, and therefore you need to manage at that time. Is that your question? Yes.
Yes.
If you listen to the slides or you pay attention to the slide, well, you say it's a major influenza, meaning that is a major one, but we have other ones as well.
Okay.
Other ones as well. But that is the major one. It's the one that exerts its influence the most. I hope
Okay.
it's clear.
Yes, please.
Okay. So salt is hydrophilic. Salt is hydrophilic. If you like, open water, open salt, and put it out there in the evening during high humidity. The next day, it has turned into water. It will draw water to itself. So sodium itself is hydrophilic, water loving. And once it's in the body, it will draw water by stimulating what is called test mechanism. Test mechanism, you drink to replace the amount and balance it. That's how the body works. Okay, so Ibrahim, your hand is up. Let's hear you and Nana. And therefore, Nana, Juma, Ibrahim, Nana, Juma, and Millicent, the three. Yes.
Thank you, sir.
Okay.
Ibrahim is talking.
Yeah, Ibrahim, let's hear you.
Sir, my question is the diagnostic evaluation and investigation for FVD.
Yeah.
Assuming in exam they ask you to mention like, let's say 3 or 4 diagnostic evaluation, and then what you gave us, I want to know whether you see the clinical manifestations. Can you mention that one as one?
Yes. So if you talk about diagnostic investigations,
Evaluation.
evaluate cut across clinical manifestations and other laboratory investigations. You understand?
Yes,
If it's
sir.
not restricted to lab, then you can go and add the clinical evaluations. You understand?
Okay, sir.
Yes.
All right. Thank you, sir.
Okay. Thank you. Yes. Nana, Donna Juma, and Millicent. Then
All right, thank you, sir.
Callistus. Yes.
All right, so my question is, you were trying to explain something about the hematocrit, hematocrit levels.
Sure.
You're using pediatric as an example, but I didn't get that point well.
You didn't get it clear?
Yes, please.
Okay. What I said exactly was that you can't just rely on hemoglobin level to transfuse a child, and you may make a very fundamental mistakes when you do that. Because if a child is having anemia, you should be able to determine the proportion of anemia this child has vis-a-vis the hemoglobin and hematocrit levels. So the process of separating the plasma from the cells is where you put it on a centrifuge machine. Then you analyze the cells. How much is this child having in his or her system? And that will determine if the cells are too low, then it means you can't put a whole blood on this child, because if the cells are low, it means that the plasma is too much. And when you put a whole blood, already it has a lot of plasma, and you are going to have overhydration, overtransfusion. So what that child needs is packed cells. So the best determinant at the pediatric ward is to check hematocrit levels if you want to transfuse a child. However, if the hematocrit levels are high, it means the cells are more, and the plasma volume is low, then you can give a whole blood, because after all, you have a very low plasma volume. And there wouldn't be any chance of causing over transfusion in terms of fluids. This was the explanation.
All right, thank you, sir.
Thank you. Yes, Callistus. Then,
Sir, sir, my question is, would you encourage the use of Pito in a fluid electrolyte imbalance?
if it's not Pito, we the nothingness, we have all been dehydrated. Though. Look at the amount of sunlight. It is the Pito that is rehydrating us. Of course, why can't we take it? It's a millet, and it's a very healthy lifestyle. Anytime I get to Tamale, I take pito, and I flush the body of its waste. It's a means of hydrating the body, and it's a healthy practice.
So I'm asking because the pito, when fermented,
I mentioned it
contains some
unfermented.
alcohol.
I mentioned
Yeah.
unfermented.
You mentioned unfermented. Okay.
Yes.
I didn't hear that. Thanks.
Okay. Yes. Thank you. Yes, Vera and Joshua. Then that's the last two. So we continue. Yes. If Vera is not talking, Vera, unmute yourself. Just press the microphone to unmute yourself, and then we can move on. If you are not talking, then we continue. Joshua?
Okay, sir. Please, sir, good afternoon.
Good afternoon.
Please, my question is, with the FVD, the fluid volume deficit, is it always initiated by the extracellular environment, fluid environment or compartment? And then my second question is that when you were talking, you talked of the loss of the same values in between the intracellular compartment and that of the extracellular compartment before we get the FVD. So my question is, the same loss that we were talking about, is it as a result of compensation? Like maybe the extracellular fluid has lost 5, and then the intra want to compensate, like replace it. So the intra will then send 5 from the inside out to compensate. That's why we have the same fluid volume lost to achieve the FVD. Thank you, sir.
Okay, thank you. It's simple. The fluid loss, whatever is coming from, whether it's vomiting, whether it's diarrhea, whatever it may be, whether it's severe bleeding, the moment these things occurs, it starts drawing fluid from the extracellular compartment. Could be from the intravascular, then followed by interstitial. If fluid loss is so low in these extracellular spaces, then the body will fall on the intracellular and start moving water from the intracellular to replace the extracellular. That is what it does. So if, for instance, you have 40 mils of fluid loss from the extracellular compartment, it may not get all the 40 from the intracellular. It may pick 20 or 30, depending upon the amount available. Then it will move from the intra to replace the extra. It will continue until you put brakes on the causes of the dehydration. Otherwise, it will continue to withdraw because what is causing the dehydration has not been stopped until at a point where you move all the fluid from the cells and the cells start shrinking. That is where you talk about the cellular shrinkage, and then severe brain damage occurs. So that is what it does. The amount of, or the percentages and the proportions was in respect to the fluid and the solute. I was talking about FVD, and I was explaining that the proportions of solute and then the fluids are lost in the same way to maintain the FVD. However, you can also have hyperosmolar, where you have too much fluid that are lost more than solute. Rep, do your work. Okay, so that is the explanation. Yes, Samuel, your hand is up. Millicent and Mohammed and Zachariah. 1, 2, 3, 4. Then we are done. Then I can move on. I won't pick anybody again. So after the lecture, the rest can ask their questions. Yes.
Okay, thank you. Okay, my question is, apart from giving Ringer's lactate and normal saline to a person who is experiencing LVD, can you also consider giving dextrose 5% to maybe a patient who is severely vomiting, since it can lead to hypoglycemia?
The Ringer's takes care of that. The Ringer's has the lactate. You know, the work of the lactate is to give energy. Okay, to give energy. So even though you have not put on the dextrose, the lactate takes care of the energy for the cells. Okay.
Okay, thank you.
Thank you. Yes, Millicent.
Sir, please. My question is, you made mention that when a client who has been dehydrated has been resuscitated with Ringer's lactate and then 0.9% normal saline solution, it is very important that you also add 0.4% chlorine solution. And I would like to know, you made mention that that one helps to clear out the excess, what do I call it? The excess of byproduct that has been retained in the body due to the dehydration. So I'd appreciate if you could throw more light on how the 0.4% solution helps in clearing out the. Thank you.
0.45% sodium chloride, called the hypotonic solution, right? Yes.
Yes, please.
That one is possible as a result of the functions I explained to you in terms of osmosis. All right. You see, the normal saline 0.9% is isotonic, right? It's isotonic to the body fluid. Is that correct? However, 0.45 and 0.9, which one is high? Which one is low?
The 0.95 is rather high and the 0.45 is low.
0.45 is low. Very good. So compare 0.45 to the body fluids. The 0.45 becomes hypotonic, low concentration. And if you put it on the patient, fluid will move from that particular area into the body cells, which is having a higher concentration of 0.9. And once it happens so, the body will be stimulated to produce more urine. And that will help to flush the system.
Okay.
That is how it works.
Thank you.
It works with osmosis.
Okay. Thank you very much, sir.
Thank you. Okay. Any other question? Yes, Zachariah.
Yeah. Hello, sir.
Yes.
Sir,
So
good
you
afternoon.
are the last. Good afternoon. Yes.
Yeah, sir. My question is in a CKD with low BPs, sir, knowing very well that fluid retention in the patient is what
we are looking at a video. Is your question on LVD?
It's kind of linked to it. So, also, all right, no, sir, but it's not.
Because we can't diverse from what we are doing.
Okay,
we need to
sir.
concentrate and remain in the scope. As we get those opportunities, we answer those questions. Otherwise, we can't move on.
All right, sir. Thank you, sir.
Okay, sure. So let's go through the nursing process. The nursing process is given to you as an assignment, and I'm going to give you a case scenario to use the nursing process to manage a patient with fluid volume deficit. So you're going to look at the nursing diagnosis of this particular scenario. You look at the outcome criteria, the nursing orders, the intervention, and the evaluation. So under the nursing process, you first have to list the patient problems. Based on the patient problems, you can diagnose the person using the nursing diagnosis criteria, the taxonomies. And as you use it, you can now prioritize those problems, and now you do your outcome criteria, you do your nursing orders, and therefore the nursing intervention. So everybody get ready. We are going to give you a scenario. So you first do assessment. And for assessment, you are using the signs and symptoms, the history taking, everything to gather your information, and therefore you can go ahead. So whatever information you gather is your tool. Loss of weight, the vital signs you get, all of them. The urine decreasing, oliguria, everything. The pulses that you take, everything. The skin assessment, pinching of the skin, and everything. Or turgidity of the skin. So all is about data assessment and the laboratory investigations. Then you do your nursing diagnosis. Do your nursing diagnosis. For example, in a patient with volume depletion secondary to uncontrolled diabetes mellitus, diagnosis may be stated as LVD related to osmotic diuresis. In diabetes mellitus, the patient produced volumes of urine as a result of osmotic diuresis. Then you plan implementations. A major goal is set. Set your objectives, how to achieve your goals. Then you intervene, setting your orders and interventions to stop the dehydration or the deficit. So get ready and let's start this. So these are laboratory tests that can be given. So you can go through the test. It's a database for you. It has all the figures there. Hematocrit reading for male and female, and then the normal range is there. Okay. So that is evaluation using the nursing process. You evaluate to make sure you have achieved your goal fully or partially. So the question is, are you ready? Are you taking your pens and your paper? Madam Amakosia, a 65-year-old businesswoman. Madam Amakosia, a 65-year-old businesswoman. Was rushed to your ward with a diagnosis of severe diarrhea and vomiting. Severe diarrhea and vomiting. 3 days. This has occurred within 3 days. And the patient is in a state of shock. The patient is in a state of shock. The clinical assessment revealed blood pressure of 80/65 millimeters of mercury, 80/65 millimeters of mercury, pulse rate of 120 beats per minute, yes, beat per minute, and respiration was 40 cycles per minute. The laboratory test revealed blood urea nitrogen and creatinine in higher quantities. Urine was scanty and concentrated. client's skin becomes or looks inelastic and dry. Using the nursing process, plan a care for this particular patient. Using the nursing process, plan a care for this nursing or for this particular patient. Using the nursing process, plan a care for this particular patient. The urine is scanty. The BP is low, 80-65. The skin is inelastic and dried. Blood urea nitrogen and creatinine are on higher levels. Assessment findings, the pulse rate is 120 beats per minute, respiration 40 cycles per minute, blood pressure 80-65. And it's in a state of shock. Plan a care for this particular patient using the nursing process. Yes, any question? Any question? Yes.
Two more.
Yes, so please look and Bismarck, let's hear you.
Okay, sir.
Yes, in 3 minutes, they will take their Zoom link. So let's be quick.
Okay, sir. Since the assessment has already been given, said we should use nursing protocol. That means are we going to skip the assessment aspect of the nursing process? And then my second question is, are we going to submit it through our G portal or how is it?
The portal. Submit it through the portal.
Okay.
So if the portal,
So
if you are, the portal may not be active now. So if the portal is not active now, you can use my mail. It's on the course outline.
So are we using the nursing care plan, or we should just write and type and then we'll send it?
The nursing care plan, if you have the soft copy, fine. If you don't have the soft copy, you can type it as a word. And then you start with the nursing diagnosis. So you go with the outcome criteria, then the nursing orders, intervention and evaluations. So, and then you start with the problems and then the strengths as for the first page. So the problems, I gave you the patient problems. Yes. So the strengths, then you do that and then you outline the problem, patient strength and their problems. Then you can move on to the next diagnosis and then you do that for me. Okay.
Thank you.
So if they have not worked on the portal and they have not finished working on the portal, you can just use the mail that I have on there. So the mail can be used to send this.
In PDF.
Okay. So this is just a picture to show that the patient is in fluid volume deficit, hypovolemia. and this patient is showing wrinkled skin and inelastic skin, pulling the back of the hand, the skin remains up, it doesn't fall, and that shows severe dehydration. It's a way of checking skin turgor. Acute weight loss, that is how we check it clinically. Yes. So, Dorcas and Isaac, I don't know if the time will allow you to speak. Fine. Otherwise, we bring the lesson to an end.